All right. Well, we are ready to introduce our fifth speaker, Dr. Ware Branch. Dr. Branch is a professor of obstetrics and gynecology and director of maternal fetal medicine and the MFM fellowship program at the Utah Health Sciences Center. He specializes in high-risk pregnancy and is internationally known for his research in antiphospholipid syndrome and thrombotic disorders, including recurrent pregnancy loss. This morning, Dr. Ware will present the talk, Antiphospholipid Syndrome. Dr.
Now, is this mic on? I hope, yeah. By the way, 40 is not old, as it turns out, so I want to be sure we know that. Thanks very much to the organizers. I've actually had a great time thus far listening to all these wonderful experts and speakers. It's been a lot more fun than going to work. So I'm emotionally disturbed to note that I have very few, very few disclosures compared to everyone else. So there. If there's a lack of evidence anywhere, it's in this field. And I like that quote, "The greatest obstacle to discovery is not ignorance, it's the illusion of knowledge." Never forget it. Today I want to identify and help us all understand the diagnosis of antiphospholipid syndrome as it currently exists, mainly by an international majority opinion, near consensus, and then to understand the indications for treatment in pregnant women diagnosed with this condition. So the first case is a 25-year-old lady who's pregnant for the first time. She's had a clot in the past, and she has a diagnosis of APS at the time of her thrombosis. She's now 4.5 weeks along by menstrual dates. Her diagnosis is confirmed by a repeatedly positive lupus anticoagulant and medium or high titer IgG anticardiolipin. She is going to seek medical care already on long-term anticoagulation, pregnancy care already on long-term anticoagulation. So she meets criteria for this syndrome. She's had a thrombotic event. She's never had a pregnancy, and so she doesn't have a clinical feature of an adverse pregnancy outcome. She's repeatedly positive for lupus anticoagulant, repeatedly positive for medium or high titer anticardiolipin. The repeatedly positive piece, I'd like to say repeatedly. Can I do that for everyone, please? Regarding treatment in pregnancy for this patient, most experts would recommend which of the following: prophylactic dose, a heparin compound and aspirin, only aspirin, warfarin, adjusted dose, heparin compound and aspirin, or fondaparinux in full anticoagulation doses. And I've never done this, but there you go. That's fun. The way I'm set up, oh look, yes, okay. Here we are. The expert opinion answer is full anticoagulation. She's come to you fully anticoagulated with a prior thrombosis. And the expert opinion answer would be an adjusted dose heparin plus low-dose aspirin. In changing her anticoagulant medication, it would be prudent most prudent, I've said, to do which of the following? She's on warfarin. She's going to go to a heparin compound. You obtain a urine pregnancy test. She's had a home positive test. Obtain a serum pregnancy test. Obtain serial HCG levels to document a normal rise, or for that matter, an abnormal rise in HCG. Obtain an obstetric ultrasound to show a live embryo, or perform a pelvic examination. Oh. There you go. Wow, okay, quite a spread. This graph should remind you that you won't likely see anything by ultrasound and, that would help you understand whether the pregnancy was an intact intrauterine pregnancy or not until about 6 weeks. The patient is just 4.5 weeks and would probably have nothing discernible in the uterine cavity by ultrasound. the HCG, the pregnancy test is going to be positive, of course, quite early on. And so she's come in with a positive home urine pregnancy test, says she's pregnant. And if you could go ahead and get another one of those. and routinely that is done in an office, by the way. But since you're going to make a fairly important medical plan to change from warfarin to other anticoagulant drugs, I think it's a good idea to obtain serial HCG levels to document a normal rise, or perhaps to find that the hormones are not rising, that HCG is not rising appropriately, suggesting an impending miscarriage or a possible ectopic pregnancy. Let's see here. When would you stop the patient's warfarin? Right this second, immediately? Not until 8 weeks, before 6 weeks, never continue her on Coumadin, or by 7 weeks gestation. I love that thing. Okay, most people think immediately. Immediately is an acceptable answer. But I would make the point on this timeline graph that the period that most authorities, just more pediatric geneticists think is risk for warfarin embryopathy is from 6 weeks until 12 weeks gestation. I've changed my practice over the years such that I don't instantly stop the warfarin at 4.5 weeks. I'd like to document a normal pregnancy if I could by HCGs, and then be sure that I stop the warfarin before 6 weeks gestation to avoid the risk of embryopathy. This patient should be counseled. Remember, she's a DVT case, APS DVT case. She should be counseled. She's at increased risk for which of the following? Iatrogenic preterm birth, fetal anemia, gestational hypertensive disease, all three of those, or only A and C. Whoops. Yeah. Got it. Very good, very good. So there are data here, and let me explain this preliminary unpublished information. This comes from the PROMISE study, which is a multi-center prospective observational study of women with either APS, lupus, and antiphospholipid antibodies, lupus but no antiphospholipid antibodies, either or, and controls. And we've been collecting patients for a number of years now and have decent numbers, although there are not tons of these people around. And the important risks you can see in the APS group and in the group with lupus and antiphospholipid antibodies are fetal or neonatal death, fetal growth restriction, preterm birth, the vast majority of which is iatrogenically mediated by concerns for severe preeclampsia, concerns for fetal growth restriction, and preeclampsia. So A and C is the correct answer. Fetal anemia, like might occur in certain other obstetrical complications, is not an important consideration here. Now I want to talk about a patient who has obstetric APS. This is a 32-year-old woman who's pregnant for the second time. Her first pregnancy ended at 22 weeks with a fetal demise. She also was diagnosed as having severe preeclampsia at that time. She has repeatedly positive lupus anticoagulant and medium to high titer IgG anticardiolipin in something of a classic way, and she's on prenatal vitamins, early pregnant. Regarding her diagnosis, which of the two might you use to label this patient as having antiphospholipid antibody syndrome, excuse me, APS? Might you say she does not have APS by laboratory criteria? You'll recall the prior slide. Might you say she meets clinical criteria for the disease based on her history of fetal death, or in C, her history of severe preeclampsia? Or does she not have antiphospholipid syndrome because she's never had a thrombosis? That thing. Right, you guys are all over this. That's the deal. The obstetric criteria for the diagnosis of antiphospholipid syndrome include an early pregnancy criterion, which is recurrent early miscarriage, and 2 late pregnancy criteria. They are fetal demise, otherwise unexplained fetal death, or delivery prior to 34 weeks for eclampsia, severe preeclampsia, or severe placental insufficiency. By the way, placental insufficiency is usually evidenced by growth restriction of the fetus measured ultrasonographically and other features that are ultrasound findings. So this patient meets criteria based on 2 features. She's had a fetal death and she's had severe preeclampsia. I will note that she got delivered for severe preeclampsia as well. And had she been 24 weeks, 25 weeks, one might have accomplished the delivery of a live-born baby rather than having had a fetal demise ensue. In this case, the most important laboratory marker for adverse pregnancy outcome linked to her antiphospholipid syndrome diagnosis is which of the following assay results? Anticard, IgG, or IgM, lupus anticoagulant, the anti-beta 2, IgG, or IgM. So there we go. Very good. Yeah, very good. It turns out relatively new information comes from a publication based on the PROMISE study to which I alluded earlier. Our group did an analysis of antiphospholipid positive patients looking for associations with adverse pregnancy outcome in the prospectively observed pregnancy. We used a composite to make life simple. That is, the adverse pregnancy outcome was either a fetal demise or fetal growth restriction or a preterm birth less than 34 weeks or preeclampsia less than 34 weeks. And the results are summarized in this table. It's a bit busy, sorry. The attributes that were considered for possible associations with the outcome are shown in the left-hand column, you see. You can see some clinical features and some laboratory features there. And then the center group shows, the center 2 columns show the primary outcome, the numbers and the primary outcome in those patients that had each of those attributes on the left present. And then to the far right, you see the primary outcome in the patients that had each of those attributes absent. So for example, if you look at prior thrombosis, of the 21 cases, 52% had the primary outcome if they had a history of prior thrombosis. And of the 110 patients without a history of a prior thrombosis, you can see that only 14% had an adverse outcome. The statistically significant associations then were with prior thrombosis, SLE, and lupus anticoagulant. Lupus anticoagulant being the laboratory marker, the other 2 obviously clinical features. You see down a bit lower that high titer anticardiolipin high titer anticardiolipin was also statistically associated, but it always traveled with lupus anticoagulant. So current evidence would suggest that lupus anticoagulant as a part of the patient's diagnosis is a finding that would predict something more of a serious outcome for pregnancy. So that's the answer. In this particular case, appropriate treatment during pregnancy would include which of the following? Now remember, she's never had a thrombosis. She did not come to you fully anticoagulated. She has a diagnosis of obstetric APS, if you will. Prophylactic or intermediate dose heparin compound and aspirin. Aspirin. Adjusted dose heparin compound and aspirin. Or D, A or B. Remember the comment about the lack of evidence. Wow. Huh. All right. So here we have to turn to what is just sort of expert opinion. There's no question about it. As Dr. Bates has previously indicated. Their abbreviations here are for American College of Obstetricians and Gynecologists and for the American College of Chest Physicians. So there's a some difference of opinion, and so the ACOG recommends either clinical surveillance with aspirin or prophylactic heparin compound and aspirin and postpartum anticoagulation. ACCP suggests low-dose aspirin based on meta-analyses suggesting that low-dose aspirin will prevent recurrent preeclampsia. Expert opinion would favor prophylactic or intermediate dose heparin compound and aspirin and postpartum anticoagulation for 6 weeks. And so you could choose either A or B and be in keeping with guidelines that are within 1 or 2 years old. Now I want to change gears a little bit because I'm going to talk about what I think is the most common presentation or consultation that you folks might have to run into, will run into, I think. And these are patients with recurrent early miscarriage. And there's about 1 or 2 of these people for every 150 or 200 women trying to achieve more than one pregnancy. And so this is a common problem. And what we really know about early miscarriage is pretty sparse. Very, very commonly, these patients are tested for antiphospholipid antibodies. So here's a case of a woman who's now pregnant again. She's had 3 losses. She's 34 years of age. And her prior evaluation, laboratory-wise, has shown that she's lupus anticoagulant negative. She's got this 21 GPL units for anticardiolipin, 18 IgM, and you see sort of similar figures for anti-beta-2 glycoprotein 1. These have only been done 1 time. She's Googled this, and you are in trouble because she's a leading expert now. Just because I'm curious to point out how little we know, preembryonic losses occurring prior to about 6 weeks gestation before a discernible embryo can be seen by sonogram might present with a crumpled gestational sac. There's a yolk sac present indicating the development of embryonic parts. And there's no visible embryo. That's one type of pregnancy loss. It's fairly common, actually. Another type is an embryonic demise, which looks remarkably different, doesn't it? You see the embryo in there. It's measurable. This one happens to be about 8.5 to 9 weeks size, but there's no cardiac activity. So this woman has antiphospholipid syndrome based on the international criteria does not have antiphospholipid syndrome, excuse me, off on the wrong foot. But based on international criteria, she has a clinical feature that is recurrent. She has 3 or more consecutive miscarriages. Authorities recommend that you ought to be sure you rule out the other known or suspected, and I think suspected might be a better term, known or suspected causes of recurrent early miscarriage before you jump to a diagnosis of antiphospholipid syndrome in any case of recurrent early miscarriage. So a good idea to think about that. I will also point out that she does not meet laboratory criteria for antiphospholipid syndrome because she doesn't have the things shown on the slide. I mean, she just doesn't have this condition by laboratory testing. So what should you do with her? And these are difficult because the patient is frustrated and she's desperate, and she's certain that because her neighbors took heparin and they all had successful pregnancies, she's certain she needs heparin. Do you consider her to have APS and manage her accordingly? Do you have her evaluated for other known or suspected causes if she hasn't been? Do you repeat the tests, which were, by the way, essentially negative? Do you conclude that the patient doesn't have the condition? Do you do B and C? And I'll leave it, I'm sorry. I can't get used to this. Okay. I think those are the 2 best answers. I'd spend a lot of time explaining why she doesn't have antiphospholipid syndrome, but I acknowledge that many patients will want to be evaluated further so that they can rest easy that they may not have antiphospholipid syndrome. In the United States, anyway, it's important to try to make sure the chart reflects credible medical logic and not overdiagnosis for the sake of future insurance. So you label somebody with antiphospholipid syndrome, you might create a problem in the long run. Let me make mention of these several studies now to show that heparin doesn't help in otherwise unexplained miscarriage. Patient may insist on it, I acknowledge. But here's a study from Scotland in which they enrolled people with 2 or more losses less than 24 weeks. They ruled out the usual causes, and the patients were antiphospholipid negative. They were randomized to get a heparin compound or aspirin. And another one is the Dutch study previously mentioned by Dr. Bates. And the patients were unexplained by conventional evaluation. She reminded me last night that they did in fact store the plasma and do thrombophilia testing later. The patients were antiphospholipid negative, and they had 3 treatment arms, or three arms in the study. On this slide, you see the live birth rates in these 2 studies. So in the middle column, low molecular weight heparin column, you see the live birth rates were 77.6% and 69.1%, and you compare that to placebo over on the far right, no statistical difference. And low-dose aspirin in the Dutch study didn't help either. More recently, there's yet another publication, randomized trial, this one from Sweden, and no statistical difference between those 3 groups. So as it turns out, as much as the patient may want a heparin compound because she is a leading expert, it probably won't do any meaningful clinical good. So now, occasionally, and in my experience, rarely, you'll see a patient who has the 3 losses in a row. Her evaluation shows that she is repeatedly positive for clinically important antiphospholipid antibodies. And so she meets diagnostic criteria, clinical and laboratory. I'm personally I'm unsure whether this overlap is causative or serendipitous, but regardless. In this case, appropriate treatment during pregnancy would be which of the following, and you've seen these selections on other slides. So you give them a heparin compound and aspirin alone, just watch them, or do either A or C. There you go. It's not quite as straightforward as you may think. And so here really, for all practical purposes, is available evidence. And you note that the available evidence amounts to some 280 patients in these 4 randomized trials. The first 2 of these trials, they would be the top 2 rows, were unfractionated heparin trials in the 90s, published in the 90s. And in the last 2 columns on the right-hand side, you see the live bursts in the heparin and low-dose aspirin group, and the live bursts in the low-dose aspirin group only. And in both the Coutet and Rye trial, the results were statistically in favor of heparin. You'll note that the live birth rates in the low-dose aspirin arms only were quite low, at around 40 to 45%. More recently, Roy Farquharson and the Toronto group published trials that involved a similar number of patients, somewhat similar number of patients, but used a low molecular weight heparin product and found no difference. Notice, please, that the low-dose aspirin arm did very well, live birth rates of 72% and 75%. So, where does the truth lie? Hard to know. This is the available evidence. The American College mentions either clinical surveillance for this patient and states that one might consider prophylactic heparin and low-dose aspirin. The ACCP suggests prophylactic or intermediate dose unfractionated heparin or low molecular weight heparin combined with aspirin. And you could go find support for either of those. So the answer is either A or C. Thanks very much for listening to this. I appreciate it. I guess there'll be questions. Yeah? Anyone? Bueller?
How did you know about the 99th percentile? The lab usually reports the 95th. Did you ask them?
Well, one of the big deficits, so the question is, how does one know whether the laboratory is reporting a positive result that's outside the 99th percentile? And I think the answer is you don't, in truth, unless the lab is particularly interested in antiphospholipid testing, in which case they'll make a big point of it in the commentary attached to the laboratory results. The field of antiphospholipid syndrome is burdened quite heavily by the problem of immunoassays and their interpretation. And that's a short but honest answer. Yeah.
My turn?
Yeah, sure.
Okay.
I think, yeah.
I'm speaking on behalf of the audience.
Yeah.
And I wanted to defend our choice of converting the first case immediately to low molecular weight heparin rather than keeping her on warfarin until 6 weeks. And for a couple reasons. One, some of us are hematologists and we don't know exactly when the patient is pregnant, and we don't have all the tools at the disposal of you obstetrician gynecologists.
I'll find out when they're pregnant right then and there. Yeah, or how far along they are.
And then the other is it's sometimes difficult to manage pregnancy failure on warfarin as opposed to low molecular weight heparin, and I don't know if you have any thoughts about that. Right. It's a little easier than trying to reverse warfarin.
True.
So sometimes that's easier, and I wondered if you had any comments about that.
No, I can buy that choice, absolutely.
So there are other reasons other than the embryo toxicity that gets that's the usual reason, and over the years that's played into some of our decisions here.
I think it's a perfectly acceptable choice.
Thanks.
I've not had much clinical trouble with, in recent years, taking care of it the way I currently do, but I accept that rational people could make the decision in that way. Yeah.
Thanks.
She just took one of my questions. The second one, though, antiphospholipid antibody testing during pregnancy. How reliable are they, and are the ranges different versus non-pregnant people?
You asked the question probably because you know there's some publications that suggest differences occur during pregnancy. In particular, that patients may be more likely positive during pregnancy, and therefore you identify the disease during pregnancy. I don't think so.
I'm not so sure you identify the disease, you just have a positive test.
Well, there you go, yeah. I don't think that, I don't think so. We are going to use the PROMISE samples to look at that because we have serial samples in fairly well characterized patients over time. And I'm fairly certain that my hypothesis that there'll be no difference in test results, no important difference in test results will prove true. More about that later.
You know, in one of your cases where the patient was diagnosed, had recurrent miscarriages and subsequently concluded not to have APLS, do you believe in the entity of seronegative APLS? Well,
that's a great question. One of my mentors does very much believe in the antiphospholipid negative antiphospholipid syndrome. If there's such a thing out there, I have no idea what it is or how to diagnose it. And I see a lot of people with pregnancy loss and people who you might think really do have features consistent with antiphospholipid syndrome and are persistently negative. But I don't have any intelligent comment about what to do with that patient. Yeah.
Right, because it's demonstrated that the use of heparin and aspirin is of no use in patients with
recurrent early loss
without APS. So, I mean, how do we know that a patient may not have seronegative APS and may benefit from that?
I don't think we do. You know, one way to think about it is, I guess, you know, leave the office, go out inside, and if it's raining, they don't have it. How about that? Yes, ma'am.
Many times we get those like antiphospholipid panels,
right?
And then you have the right clinical scenario, and the patient comes with either anticardiolipin IgA, which is 40 to 50, or even like the anti-annexin, all the others which are not part of the. So
that is a dilemma.
What do you do?
I'm pretty strict about this in my practice because those assays are not standardized for clinical use, although they are widely sold. They're not standardized for clinical use, and the kind of work that would really be necessary to prove the connections were real and that the assays were reproducible from center to center have just not been done. That kind of work has not been done. So I try as hard as I can to ignore those sorts of results. I appreciate that the recurrent early miscarriage patient who's sitting in front of you is going to be distraught if you, more than distraught, if you make little of those things. I know. But I do my best to talk them out of a diagnosis. Yeah.
What about the antiprothrombin, for example, IgG, which is high because of the risk of bleeding, and then, you know, you have this recurrent pregnancy loss?
I don't think that association with recurrent miscarriage as a causative association is real. The antiprothrombin phosphatidylserine work is, I think, interesting. It's in progress, but again, no standardized assays that I could hang my hat on. So I stick with using the international criteria to make the diagnosis of antiphospholipid syndrome. Thank you very much.